Hello, everyone. My name is Saahil A Jumkhawala, and I am an internal medicine resident at Rutgers, New Jersey Medical School and a proud CardioNerds Academy Fellow. Today, we have the pleasure of speaking with Dr. Hiroyuki Daida about the RESPECT EPA trial, the results of which were presented at the 2022 American Heart Association Scientific Sessions. Dr. Daida serves as a professor of medicine in the Department of Cardiovascular Medicine at Juntendo University in Tokyo, Japan. Dr. Daida, thank you so much for being here with us today.
My pleasure. Thank you very much for inviting me, Dr. Jamkawala.
Dr. Daida, to start us off, can you describe some of the main results of this important study?
Yes, the purpose of our study is to determine whether highly purified EPA could reduce the recurrence of cardiovascular events in patients with coronary artery disease. That's a Japanese population who receive current statin therapy and whose EPA arachidonic acid ratio is less than 0.4. And the primary endpoint is included cardiovascular death or non-fatal MI, non-fatal cerebral infarction, unstable angina requiring emergency hospitalization and revascularization, and revascularization based on the clinical findings. And we enrolled about 2,500 cases and randomized into highly purified EPA or control, and followed about 4.6 years. And the baseline EPA level is 45 to 46 micro per ml. That is a little bit higher in REDUCE-IT and much lower than JERIS study. And the primary endpoint occurred 10.9% in EPA group and 14.9% in control group at year 6. And the hazard ratio is 0.785. That was borderline statistically significant. And log p-value is 0.047. And secondary endpoint, the coronary events occurred 8% in intervention group and 11.3% in the control group. And this is statistically significant with the hazard ratio of 0.734. And in addition, we found a significant, small but significant increase of new onset atrial fibrillation as an adverse effect. That's the major findings of this trial.
Thank you for sharing that. Very important findings indeed. Would you be able to provide some of the context for the aim of the study and what the key questions were to be answered in the setting of the other trials, such as JELIS, REDUCE-IT, and other prior fatty acid trials?
Okay. Actually, this RESPECT EPA was designed almost 10 years ago. That was much before the REDUCE-IT strength was published. And also several recent omega-3 fatty acid trial, mainly primary trials. But they are also after our started this trial. So our purpose is just to confirm the result of JERIS in our current practice. That means that after the JERIS, our secondary prevention approach is rapidly changed, especially in high-intensity statin or high-dose statin is the major approach. And also, as you know, in Japanese population, the fish intake is gradually decreased. That means the baseline EPA level is lower than JERIS study. Actually, in the JERIS, their baseline EPA level is 90 micromilligram per ml. But we found in this study that is about 60 or so. So we need to confirm the effect of EPA, highly purified EPA. Actually, that is pentethyl. But 1,800 milligram a day could reduce the events in our current practice. That is our purpose.
Thank you for clarifying that. Would you be able to please describe some of the scheme of the trial and the rationale for the inclusion and exclusion criteria, please?
Mm-hmm. Our trial is open label or randomized control trial. That is a limitation, but to evaluate the effect of purely EPA on cardiovascular events. And we have also another arm, that observational arm. With it, we need to establish the EPA arachidonic acid as a biomarker. So we have two kind of studies simultaneously. But in AHA, I presented the result of RCT part. And this RCT included patient with a low EPA ratio, less than 0.4, as I said, and with coronary artery disease who received current statin therapy. Because we are focusing on the relatively low EPA population, as I said, that the patient population is changing from 10 years ago. And those patients are randomized to purified EPA 1,800 milligram a day. That's the same dose of the JELIS study, but half dose of reduce it. And the entry criteria, we have statin therapy, that is standard statin therapy, but in Japan, the secondary population need to have a high dose, maximum high dose statin. So the baseline LDL cholesterol level is 80, which is much lower than that of JELIS. In JELIS, the LDL during the treatment is 130 or so, and the baseline is 180, so much higher than our current study. And exclusion criteria is usual one. We exclude the ACS, and we excluded severe heart failure, and we excluded recent revascularization. Okay.
Thank you. That is very helpful when interpreting the results to understand the structure of the study. Dr. Daida, although the study was not powered for a statistically significant result, as you mentioned, for the primary endpoint, given the lower than estimated actual event rate, how do the results guide practice moving forward in the setting of some of the post hoc analyses data that was provided?
Yeah. Actually, the primary endpoint turned out borderline significance. Although the primary endpoint did not reach that statistically significant difference, the secondary endpoint showed us the significant reduction of coronary events. That's very important. Actually, this secondary endpoint is similar of the primary endpoint of JELIS. So we found similar effect in a secondary prevention population. And as I said, we did post hoc analysis because the primary event is borderline. So, and we exclude the patients whose EPA actually increased by greater than 30 from the control group. And we exclude the patient whose EPA did not increase by greater than 30 from the EP group. So this is kind of per protocol analysis. We found significant difference between the two groups. So we find this is perhaps real effect, means that not practically, but if we could prescribe this drug quite accurately to the patient, they may have a benefit, although it is quite difficult in the general practice. And it is also interesting to see these findings. So we may have to monitor the level of EPA in the future, because if the EPA level goes up in a certain level, we may find a significant effect. That's a very important point, I think.
Thank you for noting that. One of the other questions that arose at AHA about the study is the external validity. So given that this study was conducted in the Japanese population, what are some of the caveats when we try to apply the results of this study beyond the study population, given its individual characteristics?
Yeah. Our finding is perhaps consistent with the result of the JS and reduce it. So perhaps on the same line. So this long prognostic merit of purified, highly purified EPA could apply West patient in the Western country you have. So and also our baseline EPA level is relatively low, although that is 40 to 45 to 46. So this pass could apply certain patient population or your population. So I think this result could apply in a secondary coronary patient in Asia and also Western countries. Although we need to perhaps check the baseline EPA level, and maybe we need to adjust the dose to get a certain effect or to get a certain level of EPA.
Absolutely. And for next steps, Dr. Daida, what questions still remain unanswered for the future trials in the realm of fatty acid supplements?
Yes. This result will support the prognostic merit of EPA in a secondary prevention of coronary artery disease. That's our conclusion. But the problem is new onset atrial fibrillation. So we need to focus we need to further analyze what kind of patient could get atrial fibrillation, how we can monitor them, how we can prevent them. That is one point. And also, in a perhaps this cost effectiveness standpoint, we need to find the most beneficial patient population by EPA. So that's why we are trying to start another analysis who get most beneficial effect. And also that in a biomarker study, we can maybe we can find that the best biomarker for the prediction of the future event, and also best predictor of the efficacy of EPA.
Well, we look forward to seeing the data develop. Thank you again, Dr. Daida, for taking the time to speak with us today. And thank you and your collaborating investors so much for this incredibly important work. Take care, everyone.
Thank you.